Now let's look at the various tests which we can perform that can help us in arriving at a diagnosis of myelofibrosis. When we have a clinical suspicion, for example, we have a patient with an organomegaly and he has this non-specific symptoms of fatigue and other types of like night sweats, etc. Then on the labs, initially in the primary myelofibrosis, there is an increased purge of the cells. There will be an increased number of platelets, increased RBCs count, and the increase in the WBCs count, just like common to the other types of myeloproliferative disorders. But that is basically the initial part of the disease. Later on, when the fibrosis increases and the bone marrow is basically replaced by the fibrotic tissue, the blood cell count goes down. There will be anemia. Anemia will always be present in the latter part of this disorder, and that anemia basically signifies the primary myelofibrosis, because the extramedullary hematopoiesis is not able to compensate completely for the loss of the bone marrow, and the body requirements are not being met by those extramedullary hematopoiesis. And similarly, as we are going to see in the coming slides, there will be other types of the cells, the primitive cells like the myelocytes or the promyelocytes or the teardrop cells, that will also be present on the peripheral blood film. So anemia is a very common clinical finding in these patients, specifically in the long term. Similarly, hepatomegaly will be there. The certain other types of enzymes which signify inflammation, like the lactate dehydrogenase, its level is also increased. Alkaline phosphatase level is basically increased, but they're also very non-specific, and a large number of diseases can have these presentations. The LAP score, which can be used to basically differentiate leukemias from this disorder, it is also very non-specific. The score might be normal or it might be high or low, so that does not help us much. The major lab finding which we are going to see is the anemia, specifically in a long-term patient. But the important diagnostic tools which basically help us in definitively diagnosing this disease is the bone marrow aspiration. When we do a bone marrow exam for these patients, or the bone marrow examination, the important thing is that the bone marrow is generally inaspirable. We will have a great difficulty in aspirating the bone marrow, because basically the bone marrow cavity is basically replaced by fibrotic tissue. So it will be very difficult to aspirate the bone marrow. And when we have an aspirated sample, it is basically, it shows as a picture like this. As you can see that these large collagen molecules, these large fibrotic molecules are present, and the bone marrow largely is replaced. The blood cells are largely replaced by the fibrotic tissue. And all of these fibrosis is because of increased collagen production or the increased fibroblast growth factor leading to the collagen deposition. So the bone marrow will either be inaspirable, or whenever we'll have an aspirate of the bone marrow, it will have all this collagen deposition or all this fibrotic deposition present. The other lab finding that helps us in arriving at a diagnosis is the peripheral blood film. Now, since the bone marrow is fibrotic and it is largely producing the cells because of the mutation, it basically throws out everything that is present inside the bone marrow. So a large number of the primitive cells are going to be present. And also when the bone marrow is completely replaced by the fibrotic tissue and is not working anymore, and we have an extramedullary hematopoiesis, those extramedullary hematopoiesis sites like the spleen, as they are the basically primitive sites, so these also produce a large number of the primitive cells. So we are going to see a large number of primitive cells in these patients. Certain types of specific RBCs, like the teardrop RBCs, this RBCs which are shaped like a tear, just like this here, for example, it is a teardrop shape RBC, which is different from a normal RBC shape, which is generally biconcave. These tear-shaped RBCs are because of two reasons. Number one, either because of the fibrosis present in the bone marrow cavity, the RBCs will have a very strong, difficult time in getting out of the bone marrow cavity, and because of getting out of, in the process of getting out of that fibrosis tissue, the bone marrow shape is basically altered from a biconcave to a teardrop shape. Similarly, when the spleen is enlarged and there is a large number of there is a large number of extramedullary hematopoiesis going on there, the spleen, the RBCs have a difficult time in passing through the splenic sinusoids, and they can also assume a teardrop shape to get because of difficulty in passing through those enlarged or basically congested spaces in the, which is because of the splenic infarction. So these are the two major reasons of the teardrop shaped RBCs. Along with that, certain types of primitive cells like the nucleated RBCs can be present. RBCs generally don't have a nucleus, but if, for example, just like here, you can see a smaller nucleus here. This signifies a primitive process. This signifies that either the bone marrow is basically throwing out everything without differentiating, or it also shows out that the spleen, the primitive fetal tissues like the spleen and the liver, which were the active hematopoietic sites in the fetal life, they are the ones which are controlling the hematopoiesis. Myelocytes can also be present, promyelocytes, the band cells are there, myeloblast cells can also be present. So these three major things, the anemia along with this type of a peripheral blood film, and finally an inaspirable bone marrow or a bone marrow replaced by the fibrotic tissue. These are the conclusive evidences which we have in the light of clinical features that help us in arriving at a diagnosis. Similarly, these patients can also present with bone pains, and when you do the X-ray of these patients, you have certain classical findings, which is, as you can see here, which is basically described by the term osteosclerosis. There is sclerosis or the thickening of the bone. As the arrows show here, that the bone marrow cavity is basically replaced by the fibrotic tissue. So it is basically the bone marrow cavity is very much shrunken or limited, and there is a sclerosis of the bone marrow cavity. So you can see on the X-ray that the bone marrow is sclerosed, and that leads to the term osteosclerosis. So this is also a classical X-ray presentation of the patients presenting with long-term problems with the myelofibrosis.